can go ahead and get started. Hi, everyone. Thank you so much for being here today. My name is Callie Kesters. I'm with the Office of Population Affairs, and I have had the pleasure to be the project officer for Child Trends and their team for the last 3 years. They have done some really excellent work that started truthfully at the beginning of the pandemic. So it is really amazing to be here now and share all of the amazing work that they have done. OPA is really excited to fund these research projects that will hopefully lead to the improvement of access to and the quality of family planning services, whether they're Title X or not. So this is really exciting to share all of these practices that are going on within the community. So I know you'll find it really interesting, but I hope that you'll hear some ideas today that spark some questions, maybe inspire you in your clinic or in your work as well. So I will go ahead and pass this presentation off to Jen. Thanks so much.
Thanks so much, Callie. Hi, everyone. I'm Jen Mandel from Child Trends, and here's an overview of our webinar content for today. I will start by providing some background about the innovation study. We will do a quick walk through the toolkit. We have some exciting presenters who are providers who will describe their innovations. And then we want to make sure there's plenty of time for audience Q&A so that you can ask those presenters about their experiences. Please put questions into the Q&A as people are speaking, and we will get to them at the end. Next slide. So this is our disclaimer. We receive funding from the Office of Population Affairs. Child Trends has partnered with the School-Based Health Alliance and with OPA since 2019. And as part of that process, we have interviewed 48 family planning providers and administrators from across the country, including school-based health centers. And through this work, we identified 4 foundational approaches for providing high quality and effective care for youth. These include embedding equity into services, prioritizing adolescent-friendly care, maximizing outreach so that students can access the services that are available, and then working on those very important partnerships between providers and schools that allow for care for students. We conducted an extensive selection process to identify 4 sites for process evaluations so that we could learn more about their promising strategy. These include Nationwide Children's Hospital in Ohio, Minneapolis Health Department, La Clínica de la Raza in California, and Children's Hospital of Philadelphia with the AccessMatters. And you will be hearing from representatives from each of these 4 sites today. But first, I would like to briefly walk you through the toolkit that we developed so you can see what some of our work looks like. So this is a toolkit for improving family planning services in school settings. On the left side, as we scroll down, there are 4 foundational approaches and 4 case studies based on the topics that I just spoke about. So if we can go into the embedding equity section, this section highlights key strategies for embedding equity into family planning services for youth. As we go down to the structure section, it shows that each equity strategy in this section includes a brief description of the strategy, some case examples from schools and health centers that have implemented a similar strategy, and reflection questions for you on how to implement something similar in your location. Note that these come from practitioners from the field and from across the country that we spoke with in our interviews and case studies. So if you scroll down, we'll go to the strategies. Under equity, we have 8 strategies. And the first one is hiring staff who understand communities you serve and their lived experiences. So again, we have background information about the strategy, followed by case examples from a variety of locations implementing that strategy. This includes a high school in Seattle, Children's Hospital of Philadelphia, and a school-based health center in New York State. We follow this with reflection questions, and then we have resources that are relevant to that strategy. For example, here a toolkit on equitable hiring and onboarding of staff. So this is just one example, and we have a similar format for all our other strategies in this section and across the approaches. So we highlight a variety of strategies for each of our 4 foundational approaches. So next, we can look at the case studies and go through an example of one of those. So this is a Health Resource Center coordinators and describes how they support student care. So if we go to the left side, we see the structure of the case study. We start with an overview of the innovative practice or program. Then there's information about background and context about the program. We next see how this program or approach draws on the 4 foundational approaches that we spoke about, from embedding equity through leveraging partnerships. Then there are key recommendations tailored to this program for schools seeking to replicate similar programs in their locations. For some of the case studies, we also have a resource section with information about each of the programs. However, I'm not walking through the case studies in too much detail because we are so excited to have representatives from each of these sites here to talk about their innovations. And I will transition to Elizabeth to introduce our speakers.
Thank you, Jen. Hi, everyone. My name is Elizabeth Cook, and I'm a research scientist at Child Trends. It is such a pleasure to introduce our 6 speakers today from these 4 organizations. They represent the organizations that Jen mentioned were the focus of our process evaluations. The Child Trends team spent lots of time talking with staff from each site and learning about the innovative things they're doing to provide sexual health education and services in school settings. So today we have with us Sarah Saxby and Meg Kane of Nationwide Children's Hospital in Columbus, Ohio, Allison Moore from the Minneapolis Health Department, Erin Kramer from La Clínica de la Raza in Oakland, California, and Mela Jackson and Stephanie Schilly from AccessMatters in Philadelphia. We are honored to have each of them here to talk about the innovative things that they're doing. So we'll begin by hearing from Meg and Sarah at Nationwide Children's Hospital, where they have established the Sexual Health Education Partnership that employs health educators to deliver an evidence-based sexual health curriculum in schools and connects students to family planning services. Welcome, Meg and Sarah.
Thank you so much. So my name is Sarah Saxby, she, her pronouns. I am the project manager for teen health education and the Sexual Health Education Partnership in Columbus, Ohio at Nationwide Children's Hospital.
My name is Meg Kane. I'm a pediatric nurse practitioner and pediatric mental health specialist in school health services at Nationwide Children's Hospital. And I'm here with Sarah, and we're going to be talking about our program, and we're very excited to be here.
Next slide, please. So we're going to briefly talk about the background of our project, the goals, some of our benefits and successes, as well as our challenges and our plan for sustainability. Next slide, please. So this program began in 2014 with the crisis in Central Ohio of infant mortality. So the Infant Mortality Task Force was formed as a community response, which was many different organizations and hospitals in Central Ohio that came together that had strategies for addressing the infant mortality problem. One of the strategies was teen pregnancy prevention, and out of that came our current partnership. Also around that time, the Nationwide Children's Hospital school-based health clinics were being established. So the partnership that came out of the task force was named the Sexual Health Education Partnership. And that was a true partnership of different agencies, 4 different agencies that serve teens in terms of providing evidence-based sexual health services. And this program provided training for individuals to go out and do education in the schools and in other community organizations, and also to help refer and provide access for teens for sexual health services in clinical settings. We started that in 2019. In 2020, Nationwide Children's Hospital received an OPA grant that allowed us to expand into even more schools in Central Ohio. And we are still continuing that project. We are now in year 3. I mentioned Ohio legislature constraints because it is starting to become more of an issue in terms of delivering our curriculum, which I will talk about in a little bit. Next slide, please. So the goals of our project, there are actually 3 tiers of those goals. The first are the more population health and community level goals, such as addressing gaps in equity and access to care for teens in the community for reproductive health and sexual health services, decreasing the teen birth rate in our city, and infant mortality, both of which are very high, unusually high. And then we have kind of the program level goals, our project goals, which are the deliverables from the SHEP partnership and from the grant, as well as the clinical outcomes that we've set regarding teen health in our clinics and our reach, so the number of kids we're able to serve. And then we also had goals related to improving the field of sexual and reproductive health education by producing new curriculums and new materials and resources for folks in our community. Next slide, please.
So I'm going to talk a little bit about how the work that Sarah does kind of interplays with the work that we do in the school-based health setting. We have had school-based health centers at Nationwide Children since 2015. We've always kind of continuously sought to expand the nature of that work, the comprehensive nature of that work, at that beautiful juxtaposition between education and healthcare. You know, I think probably everyone on this call is aware that reproductive healthcare is just healthcare. And I say that not to minimize it, quite the opposite, right? It's actually to emphasize the robust nature of providing care in a setting, in that setting and in that population where access has maybe not necessarily always been a given, right? So in our school-based health centers, we focus really heavily on youth friendliness, and we do that through some very specific interventions. And I will say largely, we're going to talk about this in a minute, we do a lot of that through a quality improvement infrastructure and framework, because it helps us kind of address problem solving and track our improvement in an improvement science way that allows us to kind of give feedback directly in the system that we operate in. But a lot of that comes from, with our youth friendliness, we do that through some direct feedback with some patient satisfaction survey work, which is always an ongoing process. And our patients have gotten very comfortable with that, to the extent that they'll give feedback when we aren't necessarily looking for it. Like I got a haircut recently and changed the color, and they had some feedback around that. But that's fine, because that means that the system is working, right? So we do a lot of patient satisfaction, kind of soliciting information about how they've felt about their experience, always on an anonymous basis, but and then use that to kind of inform how we're going to do things in the clinical setting. We are really deliberate about having trauma-informed care be the standard of care, and kind of along the same vein, care across the sexuality and gender spectrum as a standard of care in all of our clinics. We are also very deliberate about having expanded access to STI testing and treatment and contraception not be predicated on disclosure of sexual history. And what I always say about this is I'm a pretty fairly comfortable and confident person in her 40s. And I'm not going to tell people my sexual history. I'm just not going to do it, you guys. So I'm not going to have more expectations of a 15-year-old than I am of myself, but that does not mean that I'm going to gatekeep healthcare in that setting. So we just offer STI testing very broadly. We offer contraception very broadly, and we allow the kids to kind of self-determine, what resources they're going to need that day. We emphasize confidentiality, and we do not assume heteronormativity in any aspect of our care. I said earlier that we're going to, we do a lot of things through quality improvement initiatives, and this really has led us to expand kind of the work that we do around like our psychosocial interventions, especially when it comes to kind of, if you work with adolescents, there's a whole lot of difficult things that they're encountering, higher risk things that they're encountering. And one of the things that's emerged for us is our work in the adolescent relationship abuse spectrum. So, very briefly, again, I'm sure this crowd is already aware, it's adolescent relationship abuse is a significant problem for our adolescents. And again, in the Venn diagram, there's a lot of overlap with our reproductive health arena. So, depending on who you ask, as many as 1 in 4 adolescents will be impacted by adolescent relationship abuse by the time they turn 18. And that, those relationship issues start as young as 12. So we talk about, we do have a pretty robust relationship abuse intervention program that we start when the kids are around 12. We talk to every single kid at least once a year, if not more so, or more frequently. And that is a program that is inclusive of digital dating violence, digital dating aggression, monitoring behaviors, reproductive coercion. And one of the outcomes of that I did not anticipate, I will be honest with you, was that it would elicit disclosure from abusers in our schools. So we've had a whole, kind of another pathway that has come from that. We also have a pretty complex and robust transition readiness program that we do with our kids, because kids who are, having maybe existing at marginalization or minoritization are at higher risk of not transitioning successfully to the adult world of healthcare. So we work we are pretty proactive about working with them around that. We also screen every single kid at almost every single visit. We don't do it at lab visits or med-only visits for mental health concerns, right? And you might be thinking, Meg, that's not necessarily the recommendation, right? It's only supposed to do it once a year. And I would agree with you, that's not the recommendation, but I would also say it's not recommended to exist at marginalization or be impacted by inequity. So that's another thing that's kind of come about in response to our patient population and their needs. And, we need to kind of be a healthcare community that meets our patients where they're at. And this is something that is very important to our patients. So finally, I guess I'll just say, kind of bringing us back to our first point, from the patient data survey that we've been working on, we have this youth advisory council that kind of has been super helpful for us. It's been really key for youth engagement. They are great advocates for us in the school population, and they're helpful for building trust, keeping us aligned with our patient. Our patients' needs and the youth voice. And it's been a lot of really great activities and interaction with the clinic. And they'll do themes, monthly themes or monthly activities. But we're also working on kind of developing some better infrastructure around, what we're doing for sustainability long term with our youth advisor, youth advocacy group. But it's been really great, and we're hopeful that what we're implementing in this clinical way will continue to support, reproductive justice, reproductive health, going forward. So thank you so much. Sarah, back to you.
Thank you. Next slide, please. So in terms of the educational intervention, we are providing an evidence-based curriculum in 21 middle schools in our biggest school district here in Central Ohio. That's a 9-session curriculum that's very comprehensive. We're also offering supportive services that enhance the curriculum, such as parent programming, summer programming, and a peer health leader program where peers, the middle schoolers, are actually trained to be peer health leaders, and they're challenged to influence their friends and family with positive health messaging. Next slide, please. So also, when I go back to enhancing the field and providing more resources for teens, we also created in 2020 and 2021 the octalk.org website, which is a really cool website for kind of aimed at younger teens and their parents to give basic education with videos, interactive games, local resources such as a clinic finder, and a lot of other cool stuff. So check out octalk.org if you are able to do that. That is something we created. Next slide, please. In terms of sustainability and future goals. So we do want to sustain this program far long into the future. So to ensure success, we are training teachers to implement our evidence-based curriculum and providing them with resources such as a sex ed cart with everything that they're going to need to teach themselves and providing that training for them. We're looking for increased reach to try to impact as many people and their families as possible, young people in the community. We'd like to diversify programming and reach other age groups and other populations in our community. We're looking for clinical support and growth to continue to expand our reach in terms of access for reproductive and sexual health care. We are advocating by trying to understand and advocate for better policies in the state of Ohio for reproductive and sexual health care and education. And finally, we are really trying to strengthen and leverage our partnerships by finding new organizations to work with in other settings. Next slide, please. I would say we have many successes. One that's not mentioned here is just the operational lift of providing education in 21 schools. So it's been a really big project, but really successful. The same for maintaining all of the 13 clinics and more coming in NCH in terms of all of the staffing and work that goes into that. But we're really proud of how we've been able to increase things like teen autonomy, self-care, self-referrals, and then all of our positive preliminary data that we're seeing from our evidence-based curriculum. And we just love our partnerships, which are creating more synergy and excitement and support for this work in the community. In terms of challenges and barriers, we understand that the stigma of all of this work continues. We're just trying to educate as many people as possible to prevent that stigma. We are working with our partners to figure out what are the challenges and barriers, how do we get over them by working together. And again, we're working to advocate for in the legislature because of the restrictive and the more restrictive coming down the line laws having to do with things like opt-in and other kinds of limits to reproductive health education. Next slide. Oh, is that it? All right. Thank you. Thank you so much.
Thank you so much, Meg and Sarah. That was an awesome presentation. Next we have, before I introduced Allison, I wanted to just remind everyone that you can put your questions in the Q&A. Currently we have 5 questions and we are seeing them, and we will take note and ask them when we get to the Q&A section of this presentation. So next we have Allison Moore from the Minneapolis Health Department school-based program, out of which health educators provide students with a variety of tailored services while building relationships with students and school staff. Welcome, Allison.
Thank you so much. It's great to be here, and I'm excited to share a little bit of our story with you all, as well as to hear all the panelists' presentations. So I am Allison Moore. I am with the Minneapolis school-based clinics, and I'm here to just explore more around how we've developed and created a health educator model. And please, yeah, go ahead. Thank you. So I'm going to give you a bit of our program overview and history of how we got here. I think that narrative story kind of helps paint the picture of how these programs evolve and change over time. I'll do a deeper dive into what our health educator role started as and what it's become, and how we've been able to utilize that role to really grow our programming and services and community connections and relationships within our school communities and beyond. And then I will also take some time to talk about some of our successes in this model and some of the challenges that we also are facing. Move on to the next slide. So the Minneapolis school-based clinics have been around since 1979. So we've been around in our schools operating for quite a while. And it came about from a partnership between the Minneapolis Public Schools and the Minneapolis Health Department. So all of our clinics are run by the Minneapolis Health Department, and we've created this model really with an intentional public health, preventive health, community-based approach. But partnership has been foundational into making this program work. So we currently operate 8 clinics, and all of our clinics are located in high schools currently. So the majority of the large high schools in Minneapolis have clinics that are operated by our health department, and we have some other community partners that also operate school-based clinics. And we provide a variety of care. We really provide preventive care, primary care, a lot of things that would fall under just physical health. Within that, we do offer reproductive care, and that's what I'll be focusing in more on in our presentation and our model. We also have mental health therapists that provide amazing resources to our students. We offer nutrition and health education, which again, I'll be focusing on more. And just to give you a sense of our scale and our scope, we average around 2,200 unique clients across all of our clinic locations and around 10,000 annual visits. So the majority of our clients see us on a regular basis. And also just to give a little bit of a context of the setting in which we work, in Minnesota, we have had a minor consent law that's been around for quite a long time, since the 70s. And what that law has allowed is that minors in Minnesota, so people under the age of 18, can consent to access all of their reproductive health care, what falls under the statute. And so they can confidentially seek out care without parental or guardian notification or consent. And that really helped the school-based clinic movement in Minnesota really grow and flourish. And so within our own clinics, under the reproductive health care umbrella, we provide contraceptive options, a full array of contraceptive options, as well as things like pregnancy testing and pregnancy options counseling, STI testing. We provide barrier methods, and we really want to make reproductive health care as accessible, as normalized, as stigma-free as possible, as everyone or many people on the call, are probably quite familiar with. The model historically really involved a medical model, so a medical provider, and currently that's typically a nurse practitioner, a physician assistant paired with a medical assistant. Move on, thank you. And so that was our model historically, and then starting in 2011, we were fortunate enough to receive funding and partnership with Hennepin County Public Health to start something new. And so we received funding to start to provide a one-to-one clinic-based intervention called the Safer Sex Intervention, which is an evidence-based model really focused at STI prevention and teen pregnancy prevention. So this grant came out of teen pregnancy prevention funding. And what it allowed us to do was to start to really create a health educator role. So for the first time, we had one health educator, me, who started, and then we utilized RNs who were already working within our clinics to help deliver this intervention. And so we were part of a rigorous research study, testing out the Safer Sex Intervention, and along with other partners across the country. And what we found within Hennepin County and across the other partner organizations is that SSI was really effective. It made a huge impact on adolescents' self-reported likelihood of having unprotected sex. So those who participated were more likely to have confidence in using protection and to reduce their risk for unprotected sex. And they also reported a growing confidence, an increasing confidence in their ability to refuse sex, to negotiate things like condoms with their partners. So we saw that this was really an impactful and effective program. And by having this opportunity to start one intervention, it really allowed us to really more deeply understand all of the ways a health educator could be a pivotal role within a clinic program and within a school-based community. So our role has really grown and expanded as we've seen the needs within our schools and seen the capacity of health educators to really fill those needs. So over time, we've really broadened the type of client one-to-one education that we provide in clinics to really encompass a broader array of topics, not just the SSI intervention, but really birth control counseling education. We can provide information on safer sex, condom use, STI testing, accessing things like emergency contraception. So really trying to be more encompassing in the role that we can provide in terms of education for clients. We also have evolved and developed a much more comprehensive group and classroom education model. So our health educators connect within the school community to a variety of groups. We reach out to offer presentations. We also seek out what topics are they interested in learning about and how can we partner, how can we connect, whether it's through a Gay Straight Alliance or through the Black Student Union, or whatever groups we're working with within our school communities. How can we be a resource and what are ways to connect and support? We also provide sexual health education within our health classes. So we offer and teach curriculum, evidence-based curriculum across our health classes in our high schools to ensure that we're really reaching all of our students, that we're providing helpful, accurate, inclusive sex education that is trauma informed, and that health educator is not only in the classroom, they can be a connector for the student back in the clinic, right? So students who will have been in our classes for sex ed will see us around the building. They'll remember, oh, Allison, yeah, she was in that class I took as a ninth grader. I remember her. She's okay. You know, she can help support me, and then it might help bridge that relationship for students to come into the clinic. We also do a lot of outreach. We know it's really, really critical for students to see us in the building, to see us out and about. We can't hide out inside our school-based clinics and expect students to come. We really need to be connected, engaged, and active in our school communities. And so health educators will do a variety of kinds of outreach, anything from tabling during the lunchroom with a spinning wheel and prizes, to showing up at school open houses and conferences and school events, to sharing announcements with students, to creating a bunch of web-based resources and supports. We want to make sure that not only our students, but our school communities and stakeholders know about our school-based services, know how to reach out and connect with us, and that every person in each of our buildings knows about the school-based clinics. And with a school population that's always changing, we always have new students coming in and students graduating and new students transferring. It's an ongoing process to really do outreach and ensure that we are visible and known and accessible to students. So another part of our program that really grew out of our health education model was creating our Teen Health Empowerment Council, and really just ensuring that youth are engaged in all of our work, that they're informing our work, and that their voice is valued and a contributing part of the work that we do. So we established our Teen Health Empowerment Council, which is really an advisory council. It's based on a peer education model where we have students from across all of our school locations who are trained in as peer educators. They advise our clinics. They do things like secret shopping to give us feedback on our services. We also hired a social media intern who helps design our social media, keep us current and up to date. Really to make sure that youth voice is centering our work. We also have taken through our health education model, really expanded and elaborated on how we evaluate our program, anything from instituting ongoing patient satisfaction surveys to pulling together and looking at annual reports of our services and using that to really inform our process and ongoing quality improvement. One thing that we've piloted and then developed, and it's now become part of our ongoing services, is creating ways to make STI testing accessible and available to all students. And so we developed a model for offering all-day walk-in STI testing at our sites. To really, again, reduce that stigma for testing, to really encourage students to come and utilize our services. And sometimes that positive peer support going in with friends can really help youth overcome some of the barriers that might prevent them from coming into clinic. And we found by making these all-day testing events happen, they're fun, they're engaging, students get prizes, we really create a positive environment to encourage that we've been able to really broaden our reach. And in particular, we've noticed by surveying people who participate that we've seen these types of events have really been able to reach our LGBTQ plus identifying students in higher percentages, as well as really connecting with male identifying students, which historically we see less of in our clinics. There is a toolkit that we've created that's linked to on this presentation, and you can also find on the Child Trends website about how to organize, how to plan, how to make these events happen. So our successes and challenges, we really have gone from one health educator to creating an entire health education team and model. And it's really become a core component of our service model, to the point where we really believe this is just absolutely necessary to what we do, and it's really improved our integration and our clinic flow. Some challenges to acknowledge: grant funding is really always an ongoing process. Much of our health education work is not billable through insurance, so that is a place we are always looking for support and ongoing resources to sustain our work. I cannot talk about challenges without acknowledging the COVID-19 pandemic and how it has impacted our schools. We were closed in Minneapolis for over a year in our high schools, and we're still very much rebuilding our entire community, as I'm sure all of everybody here has experienced. And last but not least, in May of 2020, George Floyd was murdered in Minneapolis, and the racial reckoning and the trauma and all of the impact of that on our community was obviously felt globally, but it really did impact our student community, our school-based clinics communities, and it happened at a time while our schools were closed and students were really disconnected. And so I think we're really still in a process of more deeply understanding how we move ahead, how we address the systemic racism that is embedded within our schools, within our clinics, within our community, and that has been a really impactful part of our experience that I need to acknowledge. So I'm happy to be here again, and I will be on at the end, and feel free to reach out if you have questions. Thanks, everybody.
Thank you so much, Allison. Great presentation. Next, we have Erin Kramer of La Clínica de la Raza in Oakland, California, where they have developed 2 training programs to increase students' access to and the quality of adolescent-friendly contraceptive services. Go for it, Erin.
Thank you, Elizabeth, and good afternoon, everyone. My name is Erin Kramer. I'm a family nurse practitioner and a LARC provider trainer at La Clínica de la Raza, which is a community-based federally qualified health center in Oakland, California. I'm going to spend some time talking today about a program we started at La Clínica in our 8 school-based health centers to improve the LARC experience for adolescents. We can go to the next slide. So in 2014, the American Academy of Pediatrics, and in 2018, the American College of Gynecology published policy statements on contraception for adolescents. And they recommended, and you can go to the next slide, that long-acting reversible contraceptives, or LARCs, which include the etinogestrel implant Nexplanon and all the IUDs, as first-line contraceptive options based on their efficacy, based on their safety, and on satisfaction rates. However, adolescents and young adults have consistently identified fear of a painful procedure as the largest barrier to LARC use. And this is a study out of Boston Children's Hospital in 2019 that looked at pre-procedural anxiety for IUDs and implants. And from this, more than 90% of adolescents had mild, moderate, or severe anxiety before their LARC procedure. And what's also interesting about this is that there was relatively similar anxiety in patients, whether they had an implant or an IUD procedure. So on the whole, these findings support a reproductive health imperative for improving the LARC insertion experience in an already vulnerable population with limited access to contraception. As adolescents consider their full spectrum of contraceptive options, we felt very strongly that fear should not play a role. So we started with a provider training program to improve the LARC insertion experience. You can go to the next slide. And we did this 3 ways. First, by increasing access through competency-based training. Second, by using a reproductive justice approach in contraceptive counseling. And third, by training providers in trauma-informed care for procedures. So let's talk just a little bit about the competency-based training program. We know that healthcare providers are gatekeepers of contraceptive services, and their level of training and willingness to provide LARCs are prerequisites to access. So we went through a comprehensive review that started with protocol reviews and didactic training, went through certification and review, and continued to assessment and trained according to need of specific providers. Usually that was between 3 and 10 procedures until they were signed off by that provider trainer, and they were able to communicate to the medical provider credentialing and be certified to do those procedures within our institution. So to do this at your institutions, we recommend a lot of different things. One of the biggest is to identify at least one lead trainer from among the providers at your institution who's skilled, has dedicated time to train, and is supportive. Often that there you can find someone, and sometimes you cannot. So if you do not have direct access to a highly qualified trainer, there are external resources. And one of the more robust ones is the Reproductive Health Access Project, who can connect you with a network of trained professionals. So our second part of our training involved implementing a reproductive justice approach to counseling. So some of the tenets that we review with our providers are to uphold patient autonomy. We tell patients that you are in charge of your reproductive health, and I am here to support that decision. We recognize that the adolescent is the expert in their own life. It's not about you or what you think is best for the patient. We empower their choices and we give them a plan. We always say, if you do not like your birth control method, here are some ways to follow up. And we discontinue a method for a patient whenever they want. And we explain this to them during counseling before we do the procedure, that they have full control of to decide when that is. And lastly, we train providers in trauma-informed language for procedures and for pelvic exams. So for instance, we train providers that instead of saying, I'm going to do the exam now, we train providers to say, before we start, I want you to be aware that you are in control of the pace today. If you want me to slow down, repeat myself, explain anything more, please let me know. Or if any point you want me to stop the procedure, I will. And we do this because we're modeling consent in our clinics and we're building autonomy with our patients. We are also mindful of triggering language. So for example, we use the word table and not bed. We say words like let your knees fall to the sides or towards the wall. We let the patient move into position without any touching from the provider. And we also set expectations and model the words pressure versus pain. So instead of saying the speculum can be uncomfortable, we say things like, you'll feel some pressure from the speculum. Let me know if you have any discomfort so I can try to fix that right away. And on and on and on. So I think I just want to say one more quick thing about, no, go ahead. You can go to the next slide about the pelvic exam, because we do spend a lot of time training providers about this. And that is mostly because the IUD insertion is often the first pelvic exam that an adolescent has had. So since the recommendation for cervical cancer screening has been pushed to age 21, we're often seeing patients who are very, very fearful of this procedure. So we review the speculum exam and the whole procedure while the patient is dressed. Again, we discuss the signal to pause or even stop. And we talk about using different size speculums based on the body habitus of the patient. And we really just advocate moving very slowly during this exam. So in addition to provider training, we also realized that there was a very important role for support staff. And we developed a program called LARC doula training. And we define, and you can go to the next slide, we define a LARC doula as someone who is trained to provide emotional, physical, and informational support before, during, and after a LARC procedure. And at La Clínica, we trained all of our AmeriCorps health educators and our medical assistants to be LARC doulas. So a LARC doula's work is focused entirely about the well-being and experience of the patient, paying attention only to their comfort, as well as their sense of control, participation, and understanding. We talk a lot about retaining a patient's sense of control. We empower them to have a shared role in this procedure, that it's not done something that's done to the patient, but it's done with the patient. And again, anyone can be a LARC doula. As I said, we have our health educators, our medical assistants, all trained as LARC doulas, but you do not need any clinical background. So interventions directly targeting anxiety using non-pharmacological modalities are taught. We start all the time with music, non-lyrical music. We train diaphragmatic breathing, lavender aromatherapy pillows, which actually can also be helpful to block out the harsh clinic lights. We give out squeeze balls. We do temperature regulation through cooling fans and heat packs for cramping. And you can move to the next slide. We've collated all of this into a LARC doula toolkit that we've created for all of our clinics to quickly have access to these materials. And we stock them, they look like this. So a health educator, a medical assistant can just quickly bring this into the procedure with the provider. Okay, so some challenges and barriers. Obviously, training is a big one. And also onboarding new providers. So this is just a continuous cycle. It's a heavy lift. It's a heavy lift both in time and finding financial resources to pay for these visits. There's also a lot of buy-in required. And if you have, a really wonderful supportive medical director and administration, then it makes it an easier lift. But it's important for everyone to really believe that it's important to provide these LARC services, including LARC doula support on site. And again, pandemics, so school closures, telehealth appointments, pandemic regulations, not having more than one person in a room, all complicated this. And the future, so currently we're working to publish a LARC doula training toolkit in collaboration with UCSF Bixby Center for Global Reproductive Health. And that's to help support self-guided training for external health centers who want to implement a LARC doula program in their practices. We're also reformatting our evaluation tool for a LARC doula program to learn which non-pharmacological interventions are most useful for adolescents. And we're working a little bit more on training the trainer. So identifying more skilled clinicians in the LARC provider training to build a sustainable pipeline for training.
Thanks so much, Erin. I love to hear about all of that. Our final presentation will be given by Mela Jackson and Stephanie Schilly of AccessMatters in Philadelphia. AccessMatters developed the Health Resource Center model, which is a school-based model of care where Health Resource Center coordinators work in schools to form relationships with young people and the school community, provide referrals, and create safe spaces for youth to learn more about sexual health. Welcome, Mela and Stephanie.
Good afternoon, everyone. Thank you so much for having us this afternoon. My name is Mela Jackson. I'm the Director of Family Planning at AccessMatters, and I will be presenting the slide today, but Stephanie, our Vice President of Health Access and Service Delivery, will also support during the Q&A section. So we'll start off this afternoon by talking a little bit about AccessMatters and our vision and mission. We are located in Philadelphia, Pennsylvania, and our vision is that every person has the healthcare and information that they seek. And our mission is to protect, expand, and enhance equitable access to sexual and reproductive healthcare and information for all people. Next slide, please. As I mentioned before, we really are pleased this afternoon to be here to give an overview of our health Resource Center program. And on the next slide, I did see just a brief disclaimer about our funding, which we'll get into in a couple more slides, but the Health Resource Center program is funded by the Office of Population Affairs and also by the Pennsylvania Department of Health. Next slide, please. So our health resource centers provide private, confidential, and easily accessible locations where youth can access high quality sexual and reproductive health counseling, education, and services from a trained professional. The health resource centers are based within either schools or community-based sites. And the health resource centers have been around since 1991, where we had a partnership with the School District of Philadelphia, which is ongoing, to implement the program at select district schools here in Philadelphia. And in 2015, we were provided funding from the Pennsylvania Department of Health to expand the program in other counties throughout the Commonwealth. So that's really been an exciting opportunity for us. Next slide, please. So as I mentioned before, we are duly funded from the U.S. Department of Health and Human Services Office of Population Affairs through Title X and the Pennsylvania Department of Health. Each of our health resource centers are managed by an AccessMatters Title X Family Planning Network partner within the School District of Philadelphia, and each is staffed by an experienced counselor or social worker or health educator, and their title is Health Resource Center Coordinator, and we'll get a little bit more into their role in a few slides. Next slide, please. So the core services of the Health Resource Center program are certainly sexual and reproductive health education, confidential individual level counseling utilizing a motivational, interviewing, very client-centered approach. Some of our sites do provide STI testing for gonorrhea and chlamydia, and pregnancy testing as well. If those services aren't available on site, or if there's other services needed, referrals and linkages to our Title X family planning providers in the area and other resources are provided as needed. All sites distribute condoms and other risk reduction tools, and all engage in outreach and marketing for aligning health awareness campaigns, whether that's World AIDS Day, Get Yourself Tested Month, Let's Talk Month, all of those. And lastly, all of our partners do data collection and reporting as well. Next slide, please. So our role as the direct Title X and Department of Health grantee is really to establish the guidelines and policies for the program. We provide training, capacity building, technical assistance as needs are expressed from our partners. We provide fiscal oversight and management for the program. We raise awareness for the Health Resource Center services across the state. We oversee the selection process for new Health Resource Center subrecipients, and over the course of the program, we monitor and evaluate services to ensure delivery of quality services in the Health Resource Center program. Next slide, please. So some of the responsibilities of our subrecipient agencies and our Health Resource Center partners are hiring and supervising the Health Resource Center coordinators, which I mentioned a few slides ago, are individuals who are trained to educate and counsel. And it could be a social worker, it could be someone with a case management background, but they are responsible for that hiring process. Implementation of the core services that we mentioned already, including fostering those referrals to either in-school or community-based resources as needed. Participation in meetings and trainings, whether those are ones that are hosted by us at AccessMatters or those that we share that would also be pertinent to their learning and their ongoing learning. Establishment of relationships with school personnel, and then also submitting data and other program required forms and documents, expenditure reports, data reports, things of that nature. Next slide, please. So we just wanted to give you a sense of the program's reach over the past 5 years. Next slide, please. So between FY18 and FY22, the Health Resource Center program served over 15,000 youth who had over 35,000 visits to the program during that time period. Almost 500,000 condoms were distributed in the health resource centers, and over 12,000 referrals were made to school and community-based resources. And as we mentioned already, a key component of the program is counseling, and almost 90% of the Health Resource Center visits included a counseling component. Next slide, please. So some of our program successes, just overall for the program, some of the overall benefits to the youth participating are, is that the program encourages critical thinking around sexual activity, also promotes healthy relationships and behaviors regarding sexuality, and promotes safer sexual behavior, including access to and correct use of condoms and other safer sex tools. And we've also observed a reduction in unintended pregnancies, STI and HIV infection. And then, you know, those are often facilitated by the referrals that are provided through the program to reproductive healthcare services, contraception, and testing if it's not already provided on site. Next slide, please. And so, as several of the presenters have already mentioned today, there has been an impact on the program due to COVID-19, but our Health Resource Center partners were extremely creative in identifying means to provide virtual or in-person services throughout the pandemic. So whether it was virtual group education, enhanced safety protocols on site, or an increase in social media presence, and those are just some samples of Instagram posts throughout the pandemic. They really were creative in keeping youth engaged and aware of services throughout the pandemic. Next slide, please. Just in terms of program challenges, the first challenge, you know, the ongoing impact of COVID-19, there really was a varied, I guess I'll say between our sites that are in southeastern Pennsylvania that were largely shuttered during the height of the COVID-19 pandemic, and those that were throughout the state. There was a difference in terms of being able to maintain program continuity. But those challenges are ongoing because that stability that students had and that youth had prior to the pandemic was interrupted just due to newly imposed restrictions, et cetera. So it was really difficult to maintain the program continuity, and we're seeing some of those challenges continue now. Even though a lot of our partners are very innovative in how they introduce virtual programming, some of the youth expressed difficulty in engaging. It wasn't always a confidential experience if there were others in the background, and then also, you know, ongoing technological issues and things of that nature. Some of the sporadic school closures due to the outbreaks resulted in, as I mentioned before, less instability. And so some of the result of that has been an increase in behavioral health challenges that we've observed that have impacted both the youth and the Health Resource Center coordinators. So that's an ongoing concern. And just, you know, with the lack of program continuity, challenges in meeting performance goals throughout that period. So next, one of the other things that we've seen just network-wide is a turnover of supervisor and coordination staffing, and that's disrupted to service delivery. We've heard several presenters today mention already that established trust that staff develop with youth, and just that recognizable face and knowing that someone's there when someone leaves, you know, it's kind of starting that process all over again. And the relationships that they've established with school administration and with other staff, that can make it difficult in terms of progressing towards meeting program and performance goals. So we are working with our network to troubleshoot some of those issues. So to talk a little bit about program sustainability, I just wanted to highlight the 4 pillars that were mentioned during the introduction today around embedding equity, prioritizing adolescent-friendly care, maximizing outreach and access, and leveraging partnerships. So starting off with embedding equity, the Health Resource Center program ensures that students of all racial and ethnic backgrounds, sexual orientations, and gender identities are treated with compassion and respect. And some of the ways that we do that and we support that at AccessMatters is raising awareness of personal implicit biases and systemic oppression via training, encourage our partners to create an inclusive environment, promoting self-advocacy, incorporating non-directive counseling, encouraging our partners to express openness on topics of gender identity and sexual orientation, and helping youth to improve their health literacy skills and enable warm handoffs of follow-up services. Next slide, please. And then prioritizing adolescent-friendly care, just creating safe spaces and trusting relationships, helping our partners to focus on confidentiality, safety, and respect within the health resource centers, and then modeling positive interactions with a healthcare professional. Next slide, please. And in terms of maximizing outreach and access, our coordinators use their strong relationships with students to conduct outreach and enhance opportunities for engagement. So they make sure that they have a physical presence in areas where there's high student traffic, whether that's tabling during lunch hours, giving classroom presentations, advertising health initiatives, and then doing some of the monthly campaigns that I mentioned at the top as well on specific health topics, all ways to engage youth and to also let them know when the Health Resource Center is open, what hours they'll be there, and then just making themselves visible in the school setting. Next slide, please. Lastly, leveraging partnerships. The Health Resource Center coordinators form partnerships with stakeholders both in and outside the school, with the school staff, including the nurses, the counselors, teachers, administration, and then local clinics or agencies for social service support to provide those referrals as students express their needs and would need a referral to something external to the school environment. So lastly, just to focus on a few key recommendations for implementation for folks who would be looking to implement something similar to the Health Resource Center program. So we've already talked a little bit today about how the Health Resource Center program helps youth improve their health literacy skills and helping them to make health-related decisions and actions that are right for them. We also would want to recommend a program that promotes self-advocacy and helping students and youth be prepared to speak up about their own health needs and concerns. Next, providing those warm handoff referrals to full service clinics. Certainly, the healthcare system can be very complex and overwhelming, and many youth may not have experience with navigating that. So providing an environment that's conducive to that and that really enables them to get the services that they need. Also ensuring appropriate training, both for staff at the onset when they're first hired, and then offering opportunities for ongoing learning throughout. And then creating trusting relationships with school administration and staff, just in making sure that everyone's goals and objectives are aligned and that the needs of the school and the students are being met. And then lastly, gathering feedback to meet program needs and sustain program efforts, and making sure that the recipients of the program, that they're being heard and that their priorities and needs and concerns are being addressed. So that concludes our presentation. Thank you so much.
Thank you so much, Mela. And to Stephanie too for answering some questions during Mela's presentation in the chat. Okay, so that was a lot of information from these four organizations. So much good content in there. And I know some of you have been mentioning in the Q&A that it's a lot of information. You're just trying to absorb it. But I want to remind you that the toolkit that we introduced at the beginning of this webinar covers all of this information. It includes links and resources for varying innovations. So please, we're going to put it in the chat, the link to it. It is out there, totally available to you to use. And then this webinar is also being recorded. So we will share the link and you can go back and watch it a little more slowly if that would help absorb the information. So now we'd like to transition to hearing some of the questions that may have come to mind while you were listening to these presentations. And thank you to everyone who already has shared their questions in the Q&A. But if you haven't done so, we invite you to ask your questions in the Q&A feature, and we'll select a few for the presenters to answer. They have been trying to answer them already for many of you, and so hopefully you're seeing those and getting to see the responses. But I think we're going to end up talking about some of the bigger picture questions in the next 25 minutes. So keep those questions coming, please. So the first question came in from a couple people. Christina and an anonymous person said they had questions around stigma against sexual health in rural areas. I'll read both of their comments, and then these are actually for all the presenters to, I'm sorry, any presenter that's kind of is serving a population that's maybe in a rural area where there is less acceptance of these topics can answer this. So the question is, for those of us in more rural areas where the stigma against sexual health, especially of adolescents, may be high, what strategies have been implemented to enable success in sexual education and outreach with teens? And then the anonymous person asked, how do your programs and staff overcome community concerns about contraceptive and non-abstinence only education in schools? So I will mute myself and let you all respond.
I can respond first. I have actually two thoughts about that. The first I put in the Q&A is that relationship building for me is a great way to start. So I've had a lot of districts that say, we'd love for you to come and speak to our students, but we're concerned about parents getting upset. We don't want any controversy. We're worried about the laws in Ohio or whatnot. And I'll say, I totally understand. What are some other topics that might be related that you might want some education on? Things like consent, healthy relationships. We've done some programs around prom time, talking about safety, drugs and alcohol safety, things like that. So I'll kind of start that relationship building, and then I have an opportunity to meet with parents, to meet with teachers, to hear everyone's concerns and do some education with them about what comprehensive sexual health education actually is. And I think there's a lot of kind of myths that get debunked. And so then they might be more willing to try to do a different type of program that might be a little bit more comprehensive. And so that's one strategy. The other great strategy that's worked with me in the past with working with a rural population is to conduct focus groups with teens. Just to see like what their concerns are, because a lot of times if the adults in the community hear what the teens want, that way that might get them to understand a little bit more about bringing those services to the community. So we've done that like at libraries, at existing places where teens hang out, at schools, in other groups, with allies, the teachers or other types of allies to help facilitate those. And that way we can report out to say, hey, this is what these teens really want in this community.
Does anyone have anything else to add to that? Thanks so much, Sarah. Okay. A quick kind of logistics question for Minneapolis. Is there online, or are there online courses you know of to get others trained to be sexual educators?
And yeah, I would offer there's a lot of great resources online. There's not just one specific course, but one of the places I think I put in the chat too is the Reproductive Health National Training Center. I might have that acronym wrong, but it's a great resource with a bunch of getting going trainings. And then for us, we really rely on being trained in evidence-based curricula and really participating in those trainings, as well as motivational interviewing. It's a critical tool for the impact of our educators and the work they do and really drive. So I would say like really seeking out specific training and both motivational interviewing curricula, and then some of those great resources on the Reproductive Health National Training Center would be a good place to start. but it's really ongoing. I feel like we prioritize ongoing professional development, and being current is crucial as things, information is continuing to change. We have to be in tune with our teen population, which is always challenging us to do better and be better in the work that we do.
Thanks, Allison. A question for AccessMatters. Do the health resource centers exist alongside school-based health centers, or do health resource centers exist in schools without school-based health centers?
I think Stephanie may have jumped in the chat with that, but I can also reiterate that in some of our schools, not the majority, but some of our schools, there is a school-based health center there. But in others, no, there's standalone, and so they'll have to have outside and separate referral pathways.
Thanks, Mela. There have been a few questions about the Youth Advisory Council with Nationwide. Another one just came in on that topic. I'm wondering if you guys can talk about that quickly. Sorry, my dog just got caught in my headset. If you can talk about that and what you've seen in terms of the questions that have been coming in.
Yeah, was there a specific question with this one, or?
Can you say that one more time?
I'm sorry, was there a specific question this time, or just talk about?
There was one, let's see. You guys might have just answered it. But there have been a couple. I think if we see something come up several times, I'm guessing lots of people have that question.
Yeah. So the Youth Advisory Council, we did kind of a pilot version of it, maybe about a year and change ago. And we started with just maybe a handful of students, and it worked really well. The schools where we operate, the kids have to get a certain number of like internship or volunteer hours. So we asked the school if working with us in this capacity could satisfy that requirement, and they were on board. We deliberately kind of opened up the opportunity, like we didn't want there to be like a GPA requirement or any, we wanted this to be as broadly accessible as possible. And we also made it, we had a deliberate kind of like, I don't want to say we targeted, but we like definitely made it sure that kids who were on any sort of like behavior plan or whatever, this was something that was available to them as well. That ended up being really, really successful for both parties, right? So we did this in the first 18-month rounds. Again, it was just like a handful of students, and they would come and do like a small amount of clinic work, and we would give them kind of like, we had these like door decorating assignments that we were given to do this. So they would partner with us on that. And then we would say, oh, we need to change out the bulletin board. And here's the theme for the month. We need to teach everyone about vaping, or we need to do whatever. And so they were really, really excited and great. I have no artistic skill at all. So they were really great about helping us kind of come up with a beautiful and engaging bulletin board for their peers. And so then when that was like the pilot. And then when we went back and made this more like broadly available, had like a sign up process and talked to the kids about it. We had people sign up and made it kind of like work with their schedule. Now there's like a more consistent meeting time, and the kids really just took it and flew. And we still have the same kind of like themes monthly and activities that we asked them to do, but then they said, well, actually we kind of have an agenda too. And we were like, oh sorry. And they said, there's this the kids, we see this like, because the school where I work, I'm speaking from that perspective, is a 7 to 12 school. So there's like a middle school component and a high school component, and it's the high schoolers that are kind of on the advisory council. And they said, there's these middle schoolers and they're really in need. And, we feel like we need to kind of form like a mentorship aspect to this and kind of help these kids out. And we were like, yeah, all right, go for it. And they called it the Care Corner, which I was like, oh my God. But anyway, we were really proud of them. And then, so now they are doing, they have done kind of like outreach work in the community, and they're doing, stuff with us, and they're doing stuff with the middle schoolers. And, sometimes we're like, you guys actually also have to go to school. Like you have to do that too. But it's been really great. And, this is not just happening at our school, it's happening, like we have, several different high schools within our school-based health center program, and it's happening at all of these other high schools as well. It's been, still, of course, there's some element of like building the plane as you're flying, but, just having that amount of youth engagement and like, having them have something that they feel proud of, but then also, being such advocates for this kind of access, like in the school community, it's just been, that's just so valuable. It's so valuable to everyone, who's involved. But I hope that, I don't know if that answers your question, or if anyone has suggestions, I'm open.
Thanks so much, Meg. Erin, there has been a lot of activity in the chat about LARCs and training, you guys training people, getting enough practice hours in and all of that. I haven't been able to keep up with all of your answers. You guys are doing such an awesome job of answering questions in real time. Are you seeing any kind of themes in the questions that you feel like other people may have too, and want to say anything about that?
Sure. Just happy to like generally answer the questions out loud a little bit. I think training is challenging sometimes. A lot of people ask me about volume, right? We have school health centers. Maybe we haven't historically provided LARCs, or maybe it's not as popular an option. So just like how do we increase volume within these school health centers in order to help train new clinicians? And my answer is always talking about LARCs increases volume ultimately. So the more you talk about it and just use it as part of your counseling, you already have this established rapport with your patients. And now that you do an Explanon or you do an IUD, your patients are going to feel more comfortable, again, like sort of talking a little bit about that pre-procedural anxiety, coming back to you to do those procedures. So it actually is it's a wonderful place to train in your institutions. And I like run around everywhere, doing one-off LARCs with proctored LARCs with providers wherever they are. And then I'll also bring them to my clinics, which are very, very busy, or we'll go to a women's health clinic, wherever you can find volume. So, it's a challenge, but it can be done. And LARC doula training is super, super easy. We're creating, I wish I could clone and do this training and record it and send it all out. It's very simple training to bring in people that you don't have to hire anyone new. You can train your current health educators, your current medical assistants to come into the room. Another thing that we're seeing now too with the LARC doulas is it's nice to have a chaperone, even as if you're a female provider, we're actually also advocating to have a chaperone in the room. So that's playing that role as well. There's a lot of nice roles there. We are building a toolkit that hopefully will be available at the end of the year at UCSF on the Bixby website. But if you want to be trained before that, please reach out to me. And we are doing trainings with my health educator and with myself. And then there was one more question on time, but someone had asked just about how do I educate youth interested in LARCs, specifically IUDs prior to visit for insertion, given the invasive nature and pain of the procedure? Absolutely. So part of our training for our LARC doulas is informational support before the procedure. And this can often happen days, weeks, months, and sometimes even years before a patient chooses a LARC. So our LARC doulas explain all of the procedure steps and specifically how to answer the question, will it hurt, which is everyone's question. And we do this really well. So one of the answers is it depends. And there are all of these things that we are going to provide for you at our clinic to help you along the way. And then we talk a little bit about some of our non-pharmacological interventions.
Thanks, Erin. Okay, so we have about 5 minutes left before we're going to jump back over to Jen. So I have one last question for each of our sites. And if you could kind of maybe answer it in about a minute or so. But what is one piece of wisdom or a lesson learned that you think should be shared with other folks who might just be getting started with this or want to try something new? What would you tell them? And please feel free to go in any order.
I can start, although I don't really know what to say. It's such a big question. I think just don't give up. I think in this work, we are constantly met with barriers. We're constantly told that you can't do this here, you can't do that, you can't meet with that person. You can't talk about these topics. I mean, I'd be given a list of words that I can't say in a class that it's ridiculous. So find ways around it. There's workarounds with everything. You don't have to break the law or go against policies to be able to continue doing the work. You can just find creative ways to do it, find people to partner with, find allies in the community, and you know, you'll know who those people are because you're like a small little family, right? So find those ways. So, but never give up because it's important work.
I would just add, let youth lead, really center youth voice in all of this work, really let youth lead this work and be advocates and supporters throughout the process. They know what they need, they know what care is good for them, and their voice really has to be centered. And I would add too, just don't be afraid to make mistakes. That's how we learn, that's how we grow. We didn't have a grand plan and a vision from where we started to where we got, and we really allowed the process to unfold and to learn throughout the process. Own those mistakes and keep going, correct them, and move forward. Don't be afraid to take risks because there's a lot of learning and growth in that too.
I would just say that why shouldn't it be you? You know, I think that there's a lot of opportunities, you know, especially as my colleagues have just said, that, you know, for innovation and for, you know, things turning on a dime, and you know, the world is changing constantly, and you are going to have the opportunity to step into leadership every single day, and there's absolutely no reason it shouldn't be you, because you know who you're advocating for and you know what you stand for, and your patients and your population and your community is very lucky to have you doing this work. So just go for it.
These are all such good answers, and I think Mela and I would echo all of that. And I think we would say too, particularly when it comes with building relationships at like the school level, like we've done, you obviously have to listen to youth and also really identify champions who are going to be advocates for your work within the system that you're looking to work in, and also really listen to what their concerns are every step of the way, so that you can work hand in hand in tandem with them to make sure that they feel comfortable with the work that you're doing to the extent possible. And again, don't be afraid to make mistakes, and also don't be afraid to start small in order to get your foot in the door.
Was that everyone? Mela, did you have anything to add?
Stephanie took the words right out of my mouth, and you know, since we're coming from the same place, I would definitely just echo those sentiments. I think and I've only been with AccessMatters for a year, but I really truly see the benefit of getting that school administration buy-in. There have been several new mandated initiatives that we've had to roll out this year. And that's been the ongoing conversation throughout. I mean, it's certainly for the benefit of the youth that are participating, but we've had to kind of troubleshoot and pivot at each step of the way to make sure not only the youth voices are heard, but to make sure that we're meeting the needs and concerns of the environment and the community in which we're serving. So I would just echo that sentiment. And yeah, just keep on pushing.
Thank you. And Erin, I'm so sorry too. I had forgotten that you hadn't said anything yet. So please feel free.
No, not much to add. I really would echo a lot of what my other presenters said. Just, you know, it is really iterative to work in school health centers. They're smaller. They're often we're able to innovate a little bit more quickly and try things differently. And you know, I've worked at large centers, at smaller centers, and it's really a fun place to try out new things. So I agree a little bit with what Allison was saying about make mistakes, keep trying, and just see where things fall.
Thanks. I'll hand it over to Jen.
Great, thank you. Thank you so much to all the presenters today for taking this time to describe your experiences working with youth and sharing that with us. Thanks to the audience for such thoughtful questions. We have email addresses here for each of the presenters in case anyone wants to follow up with them. There's also a link to the toolkit, which, as Elizabeth noted, is on the Child Trends website, and we have case studies for each of these sites on that toolkit, and we would love to have you come look at those. Special thanks also to all of the providers that responded to our interviews over the years and through the COVID pandemic. All of you really contributed to this toolkit as well. And then finally, really thank you at Children's to Lisa Kim and Sam Sierravino, because you did all the behind the scenes work to make sure this webinar happened. We will post the webinar on the Child Trends website in the next couple of weeks, so please keep a lookout for it and share it with your friends. Thank you all so much.